Welcome everyone to the MDA Advocacy Institute on ending disability discrimination in healthcare. I am Michael Lewis. I am MDA's Director of Disability Policy, and we are so glad all of you could join us this evening. We've got a great panel of speakers lined up. So let's go ahead and get started. Next slide, please. First, we're gonna go over some introductions and housekeeping items. Then we will have Sylvia Lee from the Disability Rights Education and Fund give an overview of the myriad barriers faced by people living with a disability in accessing healthcare. Then we will have an overview of the roles that insurance companies and programs have in determining healthcare valuations and what they will pay for and what they won't from Joe Hartner, who was MDA Director of Access Policy. And then we will have an overview of current legislative efforts to end discrimination in healthcare from Anna Fedor, who is the manager of public policy for the National Down Syndrome Society. And then lastly, we'll have time for Q&A as well as an opportunity for all of you to get involved and email your members of Congress about this issue. Next slide, please. Just a few brief housekeeping items on the bottom left-hand corner of the screen. There is a small little bubble with the closed caption symbol in it. If you need closed captioning, simply click that button and the closed caption will come on. And then on the other side of your screen, the far right hand side of your screen, you can click on the chat bubble and you can ask your questions there. Like I said, we will have Q&A both after our first speaker and at the end. Next slide. Again, my name is Michael Lewis. I'm the Director of Disability Policy here at MDA. I will be the moderator this evening. We will be joined by Joe Kartner, who is the Director of Access Policy, also here at MDA, as well as Sylvia Lee, who was a Senior Staff Attorney at the Disability Rights Education and Defense Fund, where her work includes projects to increase physical and programmatic accessibility and disability awareness in the delivery of healthcare services, as well as impact litigation to increase access for people with disabilities in myriad aspects of public and private life. Ms. Lee maintains interest in healthcare reform and the impact on people with disabilities, international disability rights, and the implementation of national disability rights laws. Recently, she had the privilege of co-teaching the disability rights law class offered at the University of California, Berkeley School of Law. She received her bachelor's, master's, and law degrees from the University of Alberta. Next, we have Anna Fedora, who was the manager of public policy at the National Down Syndrome Society, where she works with members of Congress and their staff, federal agencies, and grassroots advocates to improve policies and pass legislation that benefits the Down syndrome community. And its passion for advocacy and disability and rights grew from the friendships she made with individuals with Down syndrome and other disabilities as a young child, and was further cultivated during her time teaching high school special education. Originally from Houston, Texas, Anna holds a bachelor's degree in early childhood through grade 12 special education and a graduate certificate in nonprofit management from the Bush School of Government and Public Service. Next slide, please. First, we are going to hear from Sylvia Lee. Again, she's a senior staff attorney with the Disability Rights Education and Defense Fund. And Sylvia is going to give us an overview of the barriers that people with disabilities face in accessing healthcare services. Sylvia, take it away.
Thank you, Michael. I'm just going to give a brief description of myself. I am a woman with short dark hair, wearing glasses, and I have tan skin and a black shirt on today. So, as Michael said, I'm just going to give a brief overview of disability discrimination. It's a pleasure for me to be speaking with you and sharing a high-level overview of disability discrimination in healthcare, but of course, it's not a pleasure to be talking about the many barriers that people with disabilities face. Um, People with disabilities are widely diverse. They come in many shapes, sizes, colors. Disabilities range as well, but the common experience is of facing barriers in healthcare. Um, that's the first thing I'm going to go through is just a way of thinking about the types of barriers that are encountered. Then we'll look briefly at the sources of anti-discrimination law, primarily federal, though most states have some kind of disability non-discrimination law as well. And finally, we'll be looking a little bit more closely at the National Council on Disabilities health equity framework for people with disabilities. So to begin with, the types of discrimination, I think one of the first things that people tend to think of are the physical and structural barriers. You go to your provider's office and there are a set of stairs they forgot to mention, and you're a wheelchair user, or have another mobility disability that makes it difficult. There is no ramp, there is no elevator, and seemingly no one seems to have considered the fact that there needs to be an accessible entrance. Um, Other barriers will include pathways of travel that are obstructed, exam rooms that are just too small that you can't turn a wheelchair around in. Um, there can be a lack of signage that a person who's blind can use. There are the the the, uh, the restrooms in the facility and the healthcare facility may not accommodate someone with physical disabilities so that you can't provide lab specimens, you can't adequately use the toilet or wash your hands or reach the towels. These are pretty common barriers that are encountered, and that clearly inhibit the ability to see a provider. And also, I mean, I live in California, and in the San Francisco area. And San Francisco has a lot of these beautiful old Victorian houses. And no surprise, mental health providers can often choose to set up a private practice in such an office space, and it's on the second floor of a beautiful Victorian home with no way to get to the provider. So there are all kinds of providers, and they have all kinds of barriers to reaching them. Um, Another really common type of discriminatory barrier is we call them at Dreadif, we call them programmatic barriers, and this includes effective communication. And by programmatic, I mean the policies and practices that are part of the delivery of healthcare. And many of these policies and practices, just the way things are typically done in a healthcare in a medical office, hinder the ability of patients with disabilities to receive the same quality of care as other persons. If you just think about what may typically happen when you go to an office, even assuming you can reach the front desk, you might get handed a clipboard and told to fill out some forms. You are expected to be able to communicate, to hear, to communicate clearly, to not take extra time to communicate. You're supposed to be able to take yourself off to a corner, read the document, fill it out. Um, and then you're supposed to be able to, you'll be taken to an exam room where you'll be shown in and left alone. And there you're supposedly, you would be responsible for changing, getting out of your clothes, and hopping on to often a very high exam table. These are not things that everyone can do, and we don't think that there are things that everyone should be expected to do. Uh, so where usual healthcare practices may impose barriers, there should be modifications in the policy or procedure so that someone with disabilities can have access. Something as straightforward as offering assistance or emailing forms out beforehand to someone who has a computer or can fill it out on a mobile device, so that the provider has the information they need, the doctor has the information they need, but no one has to fill out anything or read anything or respond uh, at the office itself. Um, Another accommodation would be something like, um, I just ask straightforwardly, asking, does someone need assistance with undressing? Or does someone need assistance with getting onto the exam table? And this is a very common courtesy. You know, when doctors come to an office and you're waiting there, and you, usually as a patient you can be cold and a little anxious. They knock on the door and then they open it. But if you are hard of hearing or deaf, you may not hear that knock. So some provider offices have have a light that flashes when the provider is outside. There, if you think about it with some ingenuity and thoughtfulness, there are so many ways to get around the kinds of typical policies and procedures that they use that are used in doctors' offices, in providers' offices and spaces. And it just takes that degree of quality. Because without those changes, one's ability to get effective healthcare can be deeply affected. And one of the biggest problems is the amount of time that's given for an appointment. There's 15-minute slots where you're supposed to hurry in, get yourself ready, be seen quickly, ask all your questions, and then the doctor leaves. For someone who has a speech-related disability or communication disability, someone who may use a device, a communication device, who may just need extra time to be able to speak and to be understood clearly, and is perfectly capable of having that conversation themselves, but needs more time. That 15 minutes is deeply inhibiting you and if they insist on it, then someone with a disability may wind up having to go back for multiple appointments and going through all the pain of making the appointment, of showing up, of doing, having transportation, of just all the lost time, the lost effort uh, of 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 trying to make up for something that could have been fixed with a longer appointment. So these are some common barriers. Another one that we've seen increasing attention to in the last couple of years are attitudinal barriers. And those are assumptions on the part of providers and doctors about um, the the lifespan of a person with a disability, the quality of life of a person with a disability, and the worth of the life of a person with disabilities. Um, we saw this acutely during the COVID-19 pandemic, and there was emergence of something called crisis standards of care, by which hospitals and other facilities, when they were deep in the surge of when the pandemic was at its worst, and hospitals were short of staff, short of trained respiratory therapists, short of equipment and beds, states and hospitals began to have this discussion about, well, if we just don't have enough resources, we're going to have to make some decisions about who gets care first. Typically, what a hospital should be doing is providing care to the most wounded, the people who are closest to fatality, who need help the most. In a crisis standard of care situation, when they just didn't have enough care to go around, there was a discussion about, well, we'll have to preserve our resources for those who are most likely to recover and can get out more quickly. And in that discussion, states would they dusted off some of these old standards, crisis standards of care from 15, 20, 30 years ago. And many of them had deeply discriminatory assumptions about these things, about the worth of the worth and quality of life of people with disabilities. And so we found that some hospitals just made assumptions that if you had certain conditions, if you had what was grossly called deep mental retardation, if you had other conditions that did not necessarily affect your ability to benefit from COVID-19 treatment, but were assumed to shorten your life or to make your life somehow less worth living, then you might be further down the list of getting priority for COVID-19 treatment. That was something that many disability rights groups banded together to fight. We brought complaints with the Federal Health and Human Services um, Office for Civil Rights, and got a response that helped inform hospitals and states about how discriminatory these crisis standards of care were, and inform them that they would be fought, that people with disabilities were not just going to take being pushed down to the bottom of the list for getting COVID-19 treatment. In addition, some really interesting studies have come out lately that that are looking about physicians themselves, about the attitudes they have when it comes to uh, the worth of the lives of people with disabilities, and it's not necessarily an intentional kind of hostility. It as many people with disabilities don't face outright hostility. Sometimes it's just assumptions, charitable assumptions about what you can do or what you can't do, and assumptions about um, what you need and your dependence. So in a 2021 study, it was fascinating. It was done of over 700 physicians across the country, and it was done pre-COVID. 82.4% of these physicians reported that people with significant disability have a worse quality of life than non-disabled people. That's a very high number of doctors, over 80%, who just assume that when you have a disability, you have a worse quality of life. And yet, when people with disabilities are asked, they definitely do not think they have a poorer quality of life. Only 40%, 41% of the doctors were very confident about their ability to provide the same quality of care to patients with disabilities as non-disabled patients. And only 56% strongly agreed that they welcomed people with disabilities into their practice. So that's rather eye-opening. I don't think physicians are alone in this either. We're thinking of nurses, dentists, all kinds of healthcare providers, and the assumptions that they can make about people with disabilities. And finally, the last type of barrier that I'll briefly discuss is looking at benefit design. And that's I know that Joel later on will be talking more about health insurance as well. So this is simply to say that benefit design is what is actually covered. It's how an insurance benefit is designed, what it covers, what it doesn't cover. And right now, my organization is in the middle of a lawsuit in California against private insurers who provide individual and small group insurance. And the fact that in California, they either do not cover wheelchairs at all, or they cover them with a $2,000 cap. So for anyone who uses a power chair, who has rehabilitation needs related to that chair, spinal cord needs, you know that 2,000 does not go very far, especially for a device that can need maintenance and repair, and that also does periodically need to be replaced every 6 to 10 years. So that's a benefit design choice. That's an insurance company deciding, well, what can we cover? What can we not cover? And how can we continue to make a profit? We see that decision not to cover wheelchairs as discriminatory because everyone affected by that decision is essentially a person with a disability. So now I will just look briefly at the sources of law, uh, mostly federal law. The very first broad-based non-discrimination law was Section 504 of the Rehabilitation Act of 1973, and that prohibited discrimination in programs or activities that are federally conducted, that are a program or activity under the federal government, or that provided federal financial assistance. Um, so anyone that received federal financial assistance of any kind was subject to Section 504. And it was a very short law, um, 70 or so words, and it prohibited discrimination. And it took another 5 years, not until 1978, that the law was really fleshed out with more solid regulations about what that meant. What does it mean to not discriminate against people with disabilities? The next big leap was the Americans with Disabilities Act of 1990. And it was a big leap in that it expanded the Section 504 more broadly to not just entities or programs or organizations that received federal financial assistance. It just made it more broadly. It applied more broadly to all entities. So, for example, Uh, the Americans with Disabilities Act covers doctors' offices, it covers hospitals, and it covers providers. So that was a big change. And finally, with 2010 and the Affordable Care Act, there's a section in it, Section 1557, that is also a non-discrimination provision. And this provision is really important because it further expanded the reach of disability and other non-discrimination law to private insurance companies. Historically, these purely private insurance companies don't necessarily take federal funds. They don't rely on them. And under the Americans with Disabilities Act, under the ADA, there are some provisions that make it hard to bring a lawsuit or a complaint against purely private insurance companies. So their coverage under the Affordable Care Act and the obligation for them to be non-discriminatory is really important as well. And finally, there is if all of these laws give you and me, they give people with disabilities the right to bring a lawsuit, a complaint, and that's certainly a very important right to have. It is the club in enforcing anti-discrimination. But let's be honest, it's also really hard to bring a complaint, to bring a lawsuit against your own doctor, especially if you are in a situation where you need that doctor's medical care, where you've actually already established a relationship with that provider. Or if you want to establish a relationship with a specialist, a provider, are you going to bring a lawsuit against them and then enter that relationship, that healing relationship you want? So that's all. It makes it hard to use the laws in some ways, and also the laws can take a long time. We are hopefully finishing up now a lawsuit that we brought against the Medicaid agency in California for failing to provide blind individuals with um, notices and formats that they can actually read, large print or braille. Now, that seems like a pretty basic right to me, that when you get your notice, you should be able to understand what it says. And the technology has been around for a very, very long time. We filed that complaint, I think it was in 2018, at the end of 2018. It's been a long haul of bringing through the complaint. So litigation can take a long time, and sometimes bringing a complaint, an administrative complaint, can be something of a shortcut. So Health and Human Services Office for Civil Rights provides a complaint portal. And finally, there's another important avenue is engaging in policy work, uh, voting, um, talking to local representatives and policymakers and public health agencies about the needs of people with disabilities more broadly, and about your own family members and your own needs as a person with a disability. So I know I'm running short on time here. I'm going to just in the slide, and I've just tried to put everything in one slide. Um, Talk briefly about the National Council on Disabilities Health Equity Framework for people with disabilities. So the National Council on Disability is a small federal agency that provides recommendations to Congress about the needs of people with disabilities. And they really tackled healthcare inequality in over this past year or two. They came out with a report in February of 2022 that was revised in August 2022 that establishes 5 core components for what they call their health equity framework. The first of these is designating people with disabilities as a special medically underserved population under the Public Health Services Act. And what's important about this is it's not just a title. What's important is it unlocks a source of federal funds, and it unlocks the ability to use federal healthcare infrastructure. So, for example, it establishes scholarships for providers who will be working with people with disabilities. It gives incentives for physicians to treat a population that's designated as an underserved population. So then they get higher reimbursement from Centers for Medicaid and Medicaid services. So there are all these different incentives and funds and things that kick in once you're designated as a medically underserved population. Um, and historically, the medically underserved populations are linked to geography, which is appropriate. I think we've often had places in this country, rural areas, sometimes urban inner city areas, where it's been very hard to get healthcare. But for people with disabilities, it isn't appropriate. It's not like we're clustered. Thankfully, we're no longer all stuck together in institutions. We're we're dispersed, living independent lives all over. And what brings us together as an underserved population is not geography. So we would need to be a special designation. Uh, Number two is recognizing that people with disabilities is a health disparity population under the Minority Health and Health Disparities Research and Education Act. That's another really important one because it allows people with disabilities to be recognized as a population that experiences significant um, disadvantage in the overall rate of our disease incidence, the prevalence of our mortality and morbidity and survival rates. And it distinguishes the fact that people with disabilities are not just unhealthy because they have a disability. They experience disadvantages, structural barriers, systemic barriers, and attitudinal barriers to getting effective health care. So not everything can be laid at the feet of having a disability or a chronic condition. And the next three are very straightforward. It requires comprehensive disability clinical care curricula in all U.S. medical, nursing, and other healthcare professional schools, and disability competency. So many providers I've spoken to just feel that they've never learned how to work with people with disabilities. They've never understood disability rights. They don't know the concept. They don't appreciate that a person with disability can be more familiar with their own body and their own needs than just the diagnosis that the doctor can provide. The fourth one is requiring the use of accessible medical and diagnostic equipment, which seems like a very basic one to me. And the fifth one is improving data collection concerning healthcare for people with disabilities across the lifespan. And this is, I'm quite a data geek. This is a big one for me. I think it's critical to get more information about people with disabilities so we can establish that they experience disparities in healthcare. And so we can really get a clear sense of how disability interacts with the other personal characteristics such as race or ethnicity or LGBTQ status. There, I strongly believe that there are compounded disabilities from these factors, and we are only scratching the surface of them. So, thank you. I know I stuffed a lot in there in that time, and my contact information is at the bottom of the slide, and I'm happy to answer any questions now or and hand it back to Michael.
Thank you, Sylvia. That was a lot of great information. Did anyone have questions for Sylvia? If you want to put them in the chat. No, I don't see any. And you can contact Sylvia privately if you need to. Her email address is at the bottom of the screen, syee@dreds.org. Thank you again, Sylvia, for your time tonight. That was great. Next, we have Joe Cartner, our Director of Access Policy here at MDA, who is going to give us an overview of how insurance companies make determinations about what they will cover. Joe.
Hi, everybody. It's great to see a lot of familiar faces in the chat again. So, as Michael said, I am the Director of Access Policy here at MDA, so I handle all of our healthcare portfolios here at MDA, which ranges from everything from insurance to access to medications once they're on the market to devices and anything and everything in between. So, with that out of the way, Mark, we can go to the next slide. So, how are coverage determinations made? It's an incredibly confusing process for anybody, let alone you're a layperson. So, and it kind of falls into two buckets. There's the way the federal government does it, and there's the way that private insurers do it. So let's start with the federal government. The federal government puts out a notice of benefit payment parameters under the authority of the Centers for Medicaid and Medicare Services. Um, And essentially what this is it's the framework by which CMS administers all federally funded marketplaces. So mostly this applies to market insurance under the Americans under the ACA plans. However, where the ACA goes, Medicare and Medicaid follow, and vice versa. All three of them have very similar metrics by which they come to determinations. So it's really important to speak up and make your voice heard when these things are up for public comment. Nested inside of benefit payment parameters are essential health benefits. And so essential health benefits cover any number of things. But the thing that NBP and EHB kind of collide on is they require standardization of plans. So believe it or not, there are actually hundreds of plans in the public marketplaces that are covered under these NBBPs. So having all these plans kind of fit within a specific framework is very important, so that people can get as similar healthcare as possible, given the sheer density of plans out there. It's also it requires compliance with federal standards, which is kind of obviously very important. Um, it also covers plan marketing. So we had an issue a couple of years back where plans would market them. They'd say we're a gold plan, and so you would think that the gold plan would be better than the silver plan, would be better than the bronze plan, and so people would kind of just make choices based on these assumptions, without necessarily having the know with the information to make informed decisions about what was actually in those plans. And so part of what NBBP has started doing is making sure that the marketing of those plans, so calling yourself a gold plan, is actually accurate to what's being offered by the insurance. They also require navigation assistance. So there are numbers that you can call, and a professional will actually get on the phone or get on an email and talk to you and help you navigate to the insurance that is most effective for what you need. And then another big piece that I kind of want to highlight, as I'm sure you've all heard coming from an MDA, either through Twitter or through action alerts or things of that nature, is every state in the United States right now, at some point over the next little while, is going to be redetermining who's eligible for Medicaid on their rules. This was a process that was paused during the public health emergency and has restarted at the beginning of the year after we passed the budget last year. And one thing that NBP does is in this last round of re-ups from the notice and comment period, is it created a special enrollment period for people so that if you lose access to your Medicare, there's now a special enrollment period for you to then jump onto a plan in one of these publicly available marketplaces. The other big kind of mysterious figure in insurance is these things called pharmacy benefit managers. And you've probably, if you've been watching the news and things like that, you've probably heard PBMs come up more and more recently, because uh, Congress is starting to talk about it because it's kind of this shadowy um, mechanism by which decisions get made through insurance. And so, what are PBMs? PBMs are these kind of clearinghouses of information for how insurance entities price things and cover things. They maintain lists of formularies for covered medications. So basically, what are the various insurers across the marketplace, both public and private, um, covering? And this helps health insurers kind of navigate their way through. Okay, this plan is covering this, and so we should probably also be covering this, and things of that nature. Um, They negotiate rebates and discounts for drug manufacturers, and contact directly with individual pharmacies to reimburse drugs dispensed to the beneficiaries. And so, as you can see, they hold this really kind of outsized impact on insurers and what they cover and how they cover what they cover and at what price they cover what they cover. And very little is known, and there's very little transparency about how they come to the decisions they make, um, which is obviously very much not helpful for you, the consumer. And so Congress has started to begin drafting legislation to regulate both the transparency of PBMs, but also what PBMs are and are not allowed to do within their frameworks. So there's a lot of action moving on that, and so I just wanted to give kind of a very high level overview of what a PBM is. And I'm actually going to loop back for a second if you want more detail on what MDA has been saying about the national benefit payment parameters and essential health benefits, we signed on to 2 letters very early on in 2023 that kind of go into more detail of what we would like CMS to be looking at as we uh, talk about these things in the coming years. They're literally the first 2 things that we signed on to. So if you go to the Action Center, they'll be right there at the bottom of the 2023 list. So talking about uh, essential health benefits a little more specifically, they're periodically redetermined. They cover things like telehealth. We asked CMS to reduce utilization management, so things like prior authorization, um, and change things like health equity. So making sure that no matter who you are and what your status is in terms of race or ethnicity or financial status, you're still able to access high quality insurance. And so that's kind of how the federal framework works. But how does um, the private sector work? Private sector, most people are going to receive insurance through their employer. Is usually how plans like these, uh, you know, interact with the public. Um, and private insurers tend to look at things like the safety of the therapy that they're being asked to cover, or the clinical efficacy of the medication they're being asked to cover. So, like, does this drug actually work? And the other thing is the relative cost and effectiveness of that drug. So, as compared to the rest of the market, does this drug, one, cost more or less? And two, is it more effective or less effective than other drugs already on the market? But as you look at the literature for how do private insurers and insurers more generally um, make these decisions, even the literature, so people that write about these things for a living, note that these determinations are incredibly opaque and often don't consider the individual patient's needs. They consider the kind of broad needs of a patient community, which can be really problematic if you, as an individual patient, uh, respond better to one medication than another, but your insurance won't cover it because it's more expensive, or they've come to some decision that it's less clinically efficacious than another medication on the market, then you, as the individual who's receiving the care, can get stuck having to go through this long process of appealing your insurer to cover this drug versus another one. And to that point, let's talk about comparative effectiveness and other requirements. So, as we'll talk about in a second, qualities are kind of this large metric by which health economists look at the effectiveness of a drug, and they're very draconian in the way that they do this. They sort of operate under the assumption that an able-bodied person is a person that is going to have a better quality of life, and if you have a disability, then therefore you're automatically less. Your quality of life is less than someone who is able-bodied. So they're incredibly draconian, and we don't like them for that exact reason. Um, but there are other methods by which you can look at the value of what a drug is. The first is equal value, and I'm going to say first, second, and third here, but there are many, 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 many different metrics by which people look at these things. I'm just highlighting a few of them so that you kind of get a broad picture of what these evaluations look like. The first of which is equal value life years gained. These really are hardly much better than qualities, to be perfectly honest with you. Um, they're very similar to qualities, but what they do is they disregard um, and they still disregard quality of life improvements in what a medication can do for you. The one thing that they don't consider is life expectancy in their valuations. So a little bit better than qualities, but not that much better, seeing as they still look at quality of life improvements. So basically, a disabled person versus a non disabled person is still a thing that they're considering. Um, Health years total is another metric. They're interesting in that so qualities are going to look at life expectancy and quality of life, but health years total pulls those as one thing, one value point for what they're looking at when they're evaluating a drug. Health years total pulls those two things apart. So they're two different basis points. But the problem with health years total is that they do still consider utility in quality of life, utility meaning outcome. So again, not ideal, but a step up from QALYs and equal value life years gained, in that they are at least separating out quality of life and life expectancy as two different things to consider when considering the value of a drug for a patient. Then you have something like the efficiency frontier, which considers the specific measures of a benchmark, a condition-specific measure as a benchmark versus the rest of the drugs that are on the market for that condition. And so it looks at the one drug versus another and uses how much more an individual patient is going to be better off when comparing one drug on the market versus another. Um, So that's how those work. And then we have, just as an example, single or short-term transformative therapies, which only look at one condition. They look at gene and cell-based therapies. So this is just as a way to explain that, like, there are some metrics that look at uh, an entire field of things, and there are some metrics that look at just a specific therapy. So I know that's all really complicated, and feel free to ask me any questions in the chat, but Michael, for now, I'm going to hand it back over to you.
Thanks, Adol, for that info and overview. Next, we're gonna go to Anna. I know we're running a little long, but I promise we will still have Q&A at the end. So, Anna, take it away.
Thank you so much, Michael, and I promise I will get through this as quickly as I possibly can. So a lot of good information shared here tonight, everyone. This is fantastic. So you can go ahead and go to the next slide. Again, my name is Anna. I'm the manager of public policy at the National Down Syndrome Society. Our president and CEO, Candy Pickard, wanted to be here with you all tonight, so she sends her best. She's actually in New York today for a really exciting thing that happened for the Down syndrome community. The very first Barbie with Down syndrome was released today. And NDSS has been collaborating with Barbie for over a year now to design the final product. And so she's, I think, at CBS or some big news site right now in New York as we speak, kind of doing some really exciting media coverage about that. But she was so disappointed that she couldn't be here. QALYs is something we've been working on as a team, and Candy's been really spearheading. So she sends her best, and hopefully I can kind of fill her big shoes in the meantime. But we can go ahead and move to first starting off what are QALYs, and Joel already gave kind of a really good overview, so I will just quickly go through this piece here on the next slide. Thank you. Just a quick overview again. QALYs are, or quality adjusted life years, a cost effectiveness metric that are used in both private and federal healthcare coverage determinations. And what it does is assign a numerical index to a person's life before and after treatment. This graphic you see here is from our friends at PIPC, or the Partnership to Improve Patient Care. And every time I'm trying to explain QALYs to someone, this is the first thing I show them, because I think it is just so poignant to see exactly kind of what this looks like, and the fact that in both private and federal healthcare coverage determinations, when insurers are deciding if they're going to cover a treatment that somebody needs, they are assigning a numerical value to somebody's life, with the assumption that you see that number 1, that's the highest you can get, that there is more value to a person who is young and in perfect health than there is to anybody else with varying disabilities, ages, chronic conditions, and we just don't think that that is right. We think that is outright discrimination to assign a lower value to the life of somebody who is elderly, disabled, or has a chronic condition. So I think this is really encapsulates that. On the next slide, we kind of get into how QALYs are used. Again, you can go ahead. Thank you. going really quickly here. I want to make sure we have time for Q&A. QALYs are used in cost effectiveness measures for drug price evaluation to decide if drugs are cost effective or not. The federal government uses them to determine healthcare packages and drug pricing, and they are also used by private health insurers. However, as Joel said, it is quite opaque, meaning we really don't have a lot of insider knowledge into how exactly these are used. We know they're being used, and we know that there are direct impacts from their use that are leading to discrimination, leading to the rationing of healthcare and issues with access to coverage, but we don't always know exactly when and how they're being used. And we think that alone is problematic. But also understanding that they're being used pretty widely, and again, lead to some really discriminatory impacts. And so on the next slide, the next piece that we'll jump into is how they are discriminatory. And I'm gonna go through a few different examples here in a second, but I think what it really boils down to is that when we're assigning a lower value to the lives of seniors, the chronically ill, or people with disabilities, this could lead policymakers and payers to conclude that treatments are not worth covering. They are too expensive. And we really think that there's a lot of different factors we have to take into account here when we're talking about this issue. The first being that healthcare has to be affordable and accessible to the people who need it. We also, though, know that it cannot discriminate against people with disabilities and others from marginalized communities. And QALYs are playing a role in that discrimination happening. So we're going to go through on the next slide and a few slides here, examples of how we've seen QALYs being discriminatory. But first, just wanting to point out as well that these indicators are often determined and created by individuals who do not have disabilities. Again, there's not a lot of clarity or transparency around exactly who determined and how they determined these arbitrary numbers they've assigned. But what we do know is that people with disabilities are not taking part or not given the opportunity to take part in developing these metrics. And so these are created by able-bodied people who do not understand the day-to-day life of a person with a disability, and therefore oftentimes consider them to be in a less valuable health state. So consider that somebody with a disability is living a lower quality of life, which I know Sylvia touched on earlier, these kind of attitudinal barriers to people with disabilities accessing the healthcare that they need. And we know that's not true. When we talk to people with disabilities, they tell us the opposite, that they, like anybody else, face many challenges and barriers in their life, but having a disability does not make their life less worth living. And so we know that these are arbitrarily kind of put on people with disabilities through this system. Next slide. All right, so I mentioned we're going to get to some examples of discrimination, so bear with me. I am not a medical expert, did not go to medical school. I try my best to kind of relay this in terms that make sense to me as somebody who, is not in the medical space all of the time, but I think there's some really clear examples of ways we know that discrimination has happened. The first one was in 2014, the Institute for Clinical and Economic Review, or ICER. You're going to hear ICER or see ICER a few times on the slides. We know that ICER uses QALYs in their reports, and then that federal programs and private insurers as well also routinely use research and evidence from ICER to conclude their coverage and assessments. So we know that ICER uses QALYs, and we know that in 2014 they evaluated a hepatitis C treatment, found them to be of low value to the healthcare system, despite there being overwhelming evidence that it provided a high impact to patients, as well as doctors and patients deciding for themselves that this was the best course of treatment. And as a result, even if doctors and patients made that decision themselves that this was a treatment they wanted to pursue or felt was the appropriate treatment for hepatitis C, patients struggled to receive coverage for these treatments, and it became inaccessible to them as a result. So we know that this is one example of discrimination. On the next slide, we cover another one, again, throwing out some very health wonky terms here, but in 2015, once again, ICER assessed that PCSK9s, which are a treatment for heart disease, were not cost effective, and again, resulted in a denial of coverage at a very, very high rate. On the next slide, I believe, yes, this is one I thought would be particularly of interest to the advocates attending this call. There was a Boston Globe article released in 2021 where a parent of a child with Duchenne muscular dystrophy reported that an ICER report was used as rationale for her child being denied coverage of, I'm not going to butcher the name of this drug here, but a drug that the doctors had recommended for her child. And so I think we always have to be really clear when we're talking about this that this is not about whether or not we endorse a specific drug or treatment. It's about access and coverage to drugs and treatments based on what is decided between patients and their providers. And we believe that if a provider and a patient decide that a course of treatment is appropriate and needed for them after an individualized assessment and approach, then these arbitrary and one-size-fits-all qualities and other discriminatory metrics shouldn't be what stands in the way of them receiving access to that. This next one is one that is particularly relevant for my community that I represent, the Down syndrome community. In 2022, CMS, or the Center for Medicare and Medicaid Services, relied upon a report from ICER, and that ended up that in their national coverage determination for Aduhelm, which is the first treatment ever approved by the FDA for Alzheimer's disease. And so CMS relied on this report, and it ended up being that the initial coverage determination excluded individuals with disabilities. This, again, is really, really concerning to us because individuals with Down syndrome have an extremely heightened lifetime risk of developing Alzheimer's disease. It's actually the leading cause of death for individuals with Down syndrome. And so we saw that CMS was using these reports and these metrics to decide ultimately that our community could not have access to a drug. And again, not to endorse the drug or say that every person with Down syndrome or Alzheimer's should be taking this drug, but they should have the opportunity to have access to it if it is right for them, and for it to be covered in a way that makes it cost effective for them as an individual. Alrighty, moving right along, we can go to the next slide. Alternatives to QALYs, again, not going to spend too much time here because Joel, I think, really touched on it. In 2019, NCD said there really isn't one. There's no single alternative that serves all the functions of a QALY, and really recommended that more research is needed to figure out, okay, if we can't use QALYs and we shouldn't be using QALYs, what can we do instead? Because again, there needs to be cost effectiveness in healthcare, but that also can't come at the cost of discriminating against people with disabilities. And again, going back to people with disabilities should be included in those conversations. They should have a seat at the table. They should be at the head of the table when we're consulting and deciding, okay, what are we going to do to replace these discriminatory metrics? Next slide. And that brings us to a bill that I'm happy to share a little bit about. NDSS and MDA have really been collaborating on this for quite some time now, and excited to kind of share a little bit more about it. And that's HR 485, the Protecting Healthcare for All Patients Act. And we can go to the next slide to chat a little bit about what this bill does. So this bill would prohibit all federal healthcare programs, including Medicaid, from using QALYs in access and coverage decisions. There's already a ban on QALYs on Medicare through the ACA and the IRA, but this would really extend that provision to ensure that all federal programs, including Medicaid, are banned from using or prohibited from using QALYs in their decision making. The next slide talks a little bit more about what the path of this bill has kind of looked like. This bill was originally introduced in the 117th Congress, but reintroduced in the 118th, and has really gained a lot of traction, namely because one of the lead sponsor of the bill, Representative Kathy McMorris Rodgers from Washington, is now the chairwoman of the House Energy and Commerce Committee, where this bill has jurisdiction, or where the bill has been referred to. And she is really committed to seeing this through. Congresswoman McMorris Rodgers has a son with Down syndrome, so this is a really personal issue for her. And on February 3rd, when she called a subcommittee hearing on the bill and on the issue, our president and CEO, Candy Pickard, was actually tapped to testify and testified in support of this legislation. On March 8th, it moved to a subcommittee markup. So I'm sure you all are aware when a bill is introduced, it gets sent to a committee, but even within committees, sometimes there are subcommittees that the bill has to go through first. So this was referred to the House Energy and Commerce Subcommittee on Health. And it did pass out of committee, but it passed along party lines. And this is really kind of the major point I wanted to mention here is we're starting to see this bill and this issue really start to take a partisan slant. It passed out of subcommittee and full House Energy and Commerce Committee across party lines with solidly Republican support and no Democratic co-sponsors or votes in support of the bill. And that is because we're hearing a lot of concerns that some of the language in the bill might not be specific enough and might have the unintended consequence of running into issues with drug price negotiations and actually the cost effectiveness again of our healthcare. And so one amendment that's been proposed, we felt really just kind of replaced QALYs with the EVYLG or EVLYG metric that Joel has already kind of chatted about. We personally felt like that was really just kind of sweeping this issue under the rug, replacing one bad metric with a similarly not great metric, and really didn't get to the heart of what this bill is trying to accomplish, and that is eliminating one form of discrimination in our healthcare system for people with disabilities. And so currently, it is now being moved to the full House for a markup, and we are really advocating and are working really hard with a lot of colleagues on both sides of the aisle to make sure that they can come to a bipartisan agreement before it goes to the full House. We think that it's absolutely possible and necessary to have both parties on board, and think that there is a path forward for this bill in a bipartisan manner. But obviously, everyone has to come to the table willing to really talk about this issue and to see both sides of it. And make sure we're balancing all of those things I talked about earlier with cost effectiveness while also eliminating discrimination. On the next slide, I'm trying to get through these really quickly so we can make sure we get to Q&A, but I think this is the most important slide, and I know Michael has some really great tools to share after we wrap up, but your advocacy is critical. We really think, in our opinion, one of the parts of this bill that is just so important is that it expands these protections to Medicaid, and at least for our community, but we do think for a substantial number of people in the disability community, people with disabilities largely receive their health care through Medicaid, so they're directly impacted by the discriminatory use of QALYs. Again, this should really be a nonpartisan issue, and Congress should be taking this up in a bipartisan manner, and we are just really increasingly becoming aware of efforts to use this bill to advance other metrics. And again, we really have been talking with our congressional champions and stakeholders to advocate to them. There is no single alternative to QALYs currently in existence. So if we use this bill to just eliminate QALYs and put something else in its place that is still discriminatory, we're not really solving the problem. We're just continuing to create barriers and discrimination in our healthcare system. So the bottom line is that, again, healthcare must be affordable, but it also must be accessible, and it cannot discriminate against people with disabilities. And so this is where you all can come in and play a role. And I believe the next slide should hopefully be my last. Yep, okay, questions. But first, I want to pass it over to Michael or Mark to chat a little bit about what you can do to take action on this bill.
Thank you. And guys, if you want to take action and ask your member of Congress to vote yes on the bill that Anna talked about, you can go to our website, www.mda.org/advocacy. Mark has also put a link to the action alert in the chat. All you need to do is fill in the info and it will automatically send it to your representative. This bill is being supported by pretty much every disability rights organization in Washington. Dozens of organizations. So we really hope you'll click on that link and email your representative and encourage them to take action. Did anybody have questions for Anna, Joel, or Sylvia? again, we thank you guys very much for your time. We're sorry we went a little bit over this evening. Please feel free to visit our website, mda.org/advocacy. You can text MDA USA to 50457, or you can always email us at advocacy@mdausa.org. Thank you again, everyone, for joining us tonight. This has been recorded and will be available on our website shortly. Thanks, everyone. Have a great night.